Bueno, buenas tardes a todos. Para mí es un gusto poder dar comienzo a esta conferencia sobre enfermedades por huesos densos. También un placer poder coordinarla con una gran compañera de trabajo de la comisión directiva, la doctora Paula. Ella es médica clínica y osteóloga, docente de la maestría de Osteología y Metabolismo Mineral de la Universidad de El Salvador y médica del IDIM, del Instituto de Investigaciones Metabólicas, aparte, como dije, miembro de la comisión directiva de OMS. Paula.
Muchas gracias, doctora Lorena Brance. Un privilegio, un agradecimiento especial a ustedes, a la Comisión de Enfermedades Raras, que me ha permitido presentar nada más y nada menos que al doctor Whyte. Un honor tan nombrado por la doctora Tau, como le decía mientras compartíamos una charla. Y quiero presentarte a vos, porque ya sabemos que sos médica clínica y reumatóloga, y que sos docente de pregrado y de posgrado de la Facultad de Ciencias Médicas de Rosario, de la Universidad Nacional de Rosario, e investigadora del CONICET en metabolismo óseo. Así que un gusto estar contigo y gracias por haberme elegido nuevamente en esta presentación. Yo lo que quería es que por favor me prestaran un segundo nada más de atención para que vieran qué lindo que es esto que vamos a escuchar, ¿no? Que es enfermedades con huesos densos. ¿Es muy bueno o es muy malo? ¿Qué es bueno y qué es malo de todo esto? Pero lo va a dictar el doctor Michael Whyte de Estados Unidos. El doctor es profesor, es médico, profesor de medicina, pediatría y genética en la Facultad de Medicina de la Universidad de Washington de St. Louis, Missouri, Estados Unidos. Él es miembro del Brance Jewish Hospital y del St. Louis Children's Hospital y director médico científico del Centro de Enfermedades Metabólicas Óseas e Investigación Molecular del Hospital Shriners para niños en St. Louis, Missouri, Estados Unidos. Me decía que esto tiene una connotación muy linda, muy poética de por qué este hospital, cómo nació este hospital. El doctor Whyte obtuvo su título de doctor en medicina en Downstate College of Medicine de Brooklyn, New York, y luego tuvo una pasantía y entrenamiento de residencia en medicina interna en el Bellevue Hospital en la ciudad de Nueva York también. Después de 2 años como médico clínico asociado al NIH, Bethesda, Maryland, completó una beca de investigación en la División de Enfermedades Óseas y se unió a la Facultad de Medicina de la Universidad de Washington y al personal médico del Hospital Shriners para niños en St. Louis. Los intereses de investigación del Dr. Whyte incluyen, lo sabemos, la causa, el resultado y el tratamiento de los trastornos hereditarios del metabolismo óseo y mineral en niños y adultos. Se incluyen formas genéticas de raquitismo, como hipofosfatasia e hiperfosfatemia, hipofosfatemia ligada, al cromosoma X, osteogénesis imperfecta, afecciones que causan huesos densos, como la osteopetrosis y trastornos del recambio esquelético acelerado, incluida la enfermedad de Paget juvenil. Las investigaciones de laboratorio incluyen la caracterización de nuevos trastornos y la búsqueda de genes mutados. La correlación fenotipo-genotipo apunta a comprender mejor la patogénesis de las condiciones establecidas. La terapia de reemplazo de fosfatasa alcalina, de fosfatasa alcalina dirigida al hueso y el tratamiento con anticuerpos monoclonales anti-FGF23 han sido evaluados y aprobados por la FDA para pacientes pediátricos con hipofosfatasia e hipofosfatemia ligada al cromosoma X, respectivamente. Y el Centro de Investigación de los Hospitales Shriners para niños, St. Louis, sirvió como recurso nacional para el diagnóstico, tratamiento e investigación de trastornos del metabolismo óseo y mineral y displasias esqueléticas en niños. El Dr. Whyte es además autor y coautor, como ya lo imaginamos, de más de 400 artículos y capítulos científicos relacionados. La verdad que un placer estar aquí compartiendo con ustedes esta charla. Muchas gracias, Dr. Whyte.
Well, good afternoon, Dr. Michael Whyte, and to all the persons in this meeting. For us, it's a pleasure to be able to count with your presence, and it is a honor for both of us to coordinate your conference. We thank you on behalf of the Argentine Association of Osteology and Mineral Metabolism for your valuable conference that you will give us in a few seconds. After it, the questions will be asked to you, and now the conference of Dr. Michael Whyte.
No nos perdamos las preguntas y respuestas.
Good afternoon. I'm Michael Whyte from St. Louis, Missouri, USA, and I'm privileged to give you a 30-minute talk on dense bone diseases, subtitled Too Much of a Bad or Good Thing. And by thing, I mean bone quality. As you'll see, there are dense bone diseases where there's too much bad bone that's accumulated, but there are also dense bone diseases where good quality bone has accumulated, yet there is disease. Dense bone diseases, again, can be poor quality. Examples are osteopetrosis or skeletal fluorosis. I'll be reviewing them. But then good quality dense bone diseases, and I'll review for you the endosteal hyperostoses, sclerosiosis, Van Buchem disease, and so-called Wirth-type endosteal hyperostosis, which is now more commonly called LRP5 or 6, high bone mass. And then I'll tell you about an interesting but very rare disorder, hepatitis C-associated osteosclerosis, as examples of interesting dense bone diseases. Cumulatively, the population with dense bones, as I'll show you, is not few. So as endocrinologists, I would say that you will encounter such patients. And if you're a fellow who's on his or her way to the metabolic bone clinic, you might see a circumstance like this, where a 52-year-old woman has fractured her forearm. It was casted and healed, but then she comes for bone densitometry by DEXA, and you look and you don't see the cross mark for her density being in the normal range. And in fact, you worry that she might have the worst osteoporosis ever because you don't see the mark for her bone mineral density. So this is what happens to you when you're encountering a patient with very high bone mineral density, where that mark at the very top of the figure is actually telling you that there is density here that's well above 2 standard deviations, but doesn't really quantify it for you. And yet, to this very day, the DEXA report, be it generated by hologic or lunar instruments, will say, bottom line, that there's no increased fracture risk. How could this be? It's because the WHO criteria for diagnosing bone status hasn't changed in many years now, where understandably T-scores, young adult best bone densities, are being considered and evaluated for in the individual patient. But I show you here that in this classification, normal can be a T-score of -1 or higher. And I would say to you, that woman who fractured her arm has a bone mineral density T-score of +20, and yet it will be described in the automated report as being normal bone density, no increased fracture risk. So in dealing with high bone mass diseases, you need to look a bit more deeply into the bone densitometry report. I said that there are many of these disorders, and yes, there are the dysplasias, the skeletal disorders, where there's symmetrical abnormalities in the shaping of the bones. And these dysplasias, typically the territory of the clinical geneticist or dysmorphologist, are all associated with dense bones. Examples would be osteopetrosis and endosteal hyperostosis, like I mentioned, sclerosiosis, Van Buchem disease that we'll talk about. But then for the endocrinologist, there are metabolic causes of dense bone disease. Osteoporosis would be considered the most prevalent, and now in the United States, not Paget's, but renal osteodystrophy is second most common. But there's also skeletal fluorosis and these others that would be considered metabolic types of dense bone disease. And then there are others, often in the territory of the hem-onc physicians, apparently rare indolent forms of multiple myeloma or myelofibrosis can give you dense bones. So these are the major categories. But what I would say to you as endocrinologists is that those dysplasias are now almost entirely understood at the gene level, so that the geneticist or the physician says, endocrinologist, well, we know the gene defect, you know something about the protein, so they're coming to you, endocrinologist, into the metabolic category. So it's increasingly important that endocrinologists know about dense bone diseases. I have to review, though, skeletal formation, because pediatric and adult endocrinology are involved. All of us as adults have bone remodeling, turnover, so that we have brand new skeletons about every 7 years. But for the pediatricians, there's also growth and modeling and shaping of the skeleton that are important. And the growth and modeling in the extremities occurs because the growth plate has resting and then proliferating cartilage that pushes the bone in this direction, so that the little kid's bone becomes the bigger kid's bone. But you see that modeling or shaping is necessary to go from this to this. And there's this blue material here that has to be removed. And this is the job of the osteoclast, the bone resorbing cell. They form a not node of Ranvier, but an encoche, a ring of Ranvier, that's responsible for taking this blue away. Here's what the normal anatomy of a healthy growing bone looks like. And yes, there are modeling, shaping defects that can cause radiographically dense bone. There can be overtubulation, skinny, but still intact cortical structure that would look radiographically dense. And then there could be a shaping abnormality, sort of undertubulation, widening, where there's a lot of bony tissue here that is a modeling defect that could cause dense bones. And importantly, there are types of dense bones that you need to have in the vocabulary, and they include normal here, but thickened trabecular or spongy bone, which is called osteosclerosis, and then thickening of cortical bone, which is hyperostosis that may be endosteal here or under the periosteum, periosteal hyperostosis shown to you over here. So important definitions: osteosclerosis should be used for trabecular bone thickening, and hyperostosis for cortical bone thickening. And this has been a useful categorization over the years for the radiologist to help in the differential diagnosis, because there are disorders where cortical and trabecular bone are both increased. Osteopetrosis is a good example. Then there are those where cortical bone is predominantly increased, and Engelmann's disease, progressive diaphyseal dysplasia is an example, but so are the endosteal hyperostoses. And then you have trabecular bone predominantly, and they could be from these etiologies or pathogeneses, but you can have trabecular bone predominantly causing high bone density. So what are the bad disorders? We'll talk about osteopetrosis, marble bone disease, first described by this early in his career as a surgeon, went on to buy an X-ray machine, do röntgenography, and became the first radiologist, Heinrich Albert Schönberg. And his name will live forever as reporting the first case when he went to a medical meeting in Hamburg, Germany. And in this very tiny paragraph in German, said that a young man stepped into a pothole, broke his femur, and when he did röntgenography, there were very dense bones and there were undiagnosed fractures elsewhere. So here's the first description. But we now know that osteopetrosis should not be used sort of generically to describe dense bones. It represents a global failure of osteoclast-mediated skeletal resorption. So the osteoclasts are not working. They don't work, but they're there, or they don't form in the first place. They're not around to resorb the skeleton. And the gross anatomists or the radiologists knew that that was the pathogenesis of true osteopetrosis, because the medullary canal would not form, and that's the job of the osteoclast. And that blue stuff that I showed you would not be resorbed because the osteoclast action had failed, so you would get an Erlenmeyer-Flask deformity. But the proof for osteopetrosis being failure of osteoclast comes if you look at the growth plate. You remember that there are resting cartilage, proliferating hypertrophic cartilage, and then down here as blood vessels come in, the calcified cartilage should be removed, and right about here you should get trabecular bone forming. But in the case of true osteopetrosis, if you biopsy far away from the physis, the growth plate, you'll see well mineralized bone, but you'll see persisting calcified primary spongiosa that we call cartilage bars or islands. So this shows you that the osteoclasts never took that away and therefore were failing to do their job. That's the definition of true osteopetrosis. This leads to brittle bones with a chalk stick fracture, like you broke a piece of chalk. And why is that? There's defective modeling. Erlenmeyer-Flask might not be good for skeletal health. There's the cartilage bars. The osteoclasts aren't working, so there's very slow bone remodeling and hardening of hydroxyapatite crystals. Importantly, osteons don't interconnect. The collagen doesn't become interwoven, and therefore the bones become brittle. And if you get a microfracture, the osteoclast won't help to repair the fracture. So there are these explanations for the brittleness. Osteopetrosis traditionally has been either a malignant infantile form or a benign adult form, where its prevalence in the United States is for the malignant about 1 in every 500,000 patients, higher elsewhere, and by that I'm referring probably to Europe, whereas the benign adult form has this prevalence here in the USA, but in Europe it's actually pretty prevalent. 1 per 20,000 is thought to have benign adult osteopetrosis. Where's the malignant form common? Well, it's here, Costa Rica, Middle East, and in places in Russia and Sweden. Malignant osteopetrosis looks like this clinically, and then radiographically, there's no medullary space. So with no medullary space, you have a leukoerythroblastic anemia. You don't have white cells, red cells, or platelets forming. And then the cranial foramina don't widen. The osteoclast should be making them wide, and therefore the nerves grow, but they get pushed on by a narrow foramen, and cranial nerve palsies are common. So that the symptoms and signs of malignant osteopetrosis could be choanal stenosis with nasal stuffiness. These infants will look like they have a stuffy nose, a cold all the time. They could have the anemia from hemolysis and hypersplenism with hypersplenomegaly, recurrent infection, and then cranial nerve palsies, often optic, oculomotor, or facial, and delayed eruption of the teeth. The osteoclast would have to make a eruption canal for the teeth, and if they're not working, delayed eruption of the teeth is characteristic. Whereas in benign osteopetrosis, and I'll call it Albert-Schoenberg disease, there can be skip generations, but for those clinically affected, fractures, hearing loss, sometimes vision, facial nerve palsy, osteomyelitis because there's poor blood supply to the jaw, and interesting spondylolysis, cracks in the posterior elements of the vertebrae because the vertebrae themselves are brittle. Over the years, along came also an intermediate osteopetrosis. This was one of my patients a number of years ago. His x-rays looked like this. He became transfusion dependent and died probably in his middle 20s. And then a clinical sort of nosology developed. You had malignant, you had benign, you had osteopetrosis with neuronal storage disease, recessive. And then in the 1980s, this developed. 2 alleged types of adult osteopetrosis, both inherited as autosomal dominants, the so-called type 1 and type 2. And this was from the work of Boleslav and Anderson, where they, in the late 1980s, looked at the X-ray, biochemistry, and inheritance pattern, and they thought they saw two types of autosomal dominant osteopetrosis. This engendered confusion. Albert-Schoenberg disease, the true osteopetrosis, was called ADO2, base of the skull particularly dense, and a rugged jersey spine are the radiologic characteristics, whereas in so-called ADO type 1, the calvarium was thick. There was no rugged jersey spine, but instead uniform density. It turned out that type 2, Albert-Schoenberg disease, as I like to call it, not ADO2, was truly an osteopetrosis, whereas type 1 is LRP5 activation that I hope to show you, and is not an osteopetrosis. The mechanism is increased bone formation. So what's the etiology and molecular pathogenesis of the osteopetrosis? Years ago, these three affected sisters and their taller unaffected sister came with the first one having had a fracture, thought to have malignant osteopetrosis, predicted to die soon, but obviously they didn't. And instead, the radiographs became less dense. Bill Sly thought, what could be the mechanism here? And in the so-called pre-DNA era, we measured carbonic anhydrase deficiency and found it to be the primary defect in their form of osteopetrosis, which was autosomal recessive with renal tubular acidosis and cerebral calcification. And here, carbonic anhydrase was deficient. In order for osteoclasts to resorb the skeleton, they have to make hydrochloric acid. CO2 would enter the osteoclast. It would be hydrated by carbonic anhydrase, and then a proton would be sent out to combine with chloride to make the hydrochloric acid, and the bicarb would be exchanged for the chloride that would make hydrochloric acid. So here, with the carbonic anhydrase 2 deficiency, this acidification would not occur properly. And it turns out that many of the defects that underlie now the molecular defects, the gene defects that cause autosomal recessive osteopetrosis, are involved in making hydrochloric acid. These are the genes that are now identified by mutation analysis. One of them is expressed not only in the osteoclast to help make acid, but also in the gastric mucosa, so that a term osteopetrorickets, a paradox of dense bones, yet hypocalcemia, secondary hyperparathyroidism, can occur when there's TCIRG1 mutations. This is part of the proton pump in the stomach and in bone. The other common mutation that underlies recessive malignant osteopetrosis, but also Albert-Schoenberg disease, monoallelic, is a chloride channel 7 mutation. Pycnodisostosis was thought to be a separate skeletal dysplasia. Here's Henri Toulouse-Lautrec, who was thought to have pycnodisostosis, where the first mutation identified to be associated with dense bone disease was found in the 1990s to involve cathepsin K deficiency. The bones look like this. So yeah, they're osteopetrotic-like. And after the acid takes away the mineral, cathepsin K is necessary to clean up some of the matrix by the osteoclast. So here's another mechanism, non-acidification involved in osteopetrosis. 70% are autosomal recessive osteopetrosis involving either TCIGR1 or chloride channel 7. There's a nice summary. It's in 2013, but Sabacci and colleagues in Nature Reviews Endocrinology would talk about genes causing recessive osteopetrosis, talk about growth, hypocalcemia, etc., life expectancy. A very nice review. But here, they're talking about whether osteoclasts are present and very importantly, whether or not they're actually absent in some patients. And that's very important for therapy and understanding pathogenesis. So osteoclast-rich and osteoclast-poor osteopetrosis exist. Most of the rich forms involve these genes, but the osteoclast-poor forms involve rank ligand, rankle, or rank, and the genes that encode them. You remember how OPG binds rank ligand. If rank ligand couples to rank, you get osteoclastogenesis. Well, the rank mutations causing osteopetrosis are intrinsic defects to the osteoclast, but those causing rank ligand deficiency, with the rank ligand coming from osteoblasts or from mesenchymal cells, gives you a form of osteopetrosis that's not centered in osteoclasts themselves, but lies elsewhere. And this is important for treatment. Considering bone marrow transplantation, you could do bone marrow transplantation if successfully, if there's a defect in the osteoclasts themselves, but not if there's a defect in rank ligand production, because forming new osteoclasts won't solve the problem. There's also pharmacologic osteopetrosis. Remember, osteonecrosis of the jaw, you might think, was the first complication of aminobisphosphonate and then atypical femoral fractures. But this boy came to us years ago with what? An elevated alkaline phosphatase that was mysterious, aches in his legs, but everything that was done showed that he had a normal skeleton until he got relatively enormous doses of IV permidronate that caused clubbing, or an Erlenmeyer flask deformity, as his osteoclasts were shut off. So in 2003, we reported the first complication of aminobisphosphonate to be bisphosphonate-induced osteopetrosis. 5 years later, as he grew, this became that. The sclerotic bone off of permidronate became osteopenic, and I must say, I don't know anything further about him and what happened with his skeletal situation after we reported this in 2008. Okay, that's osteopetrosis. What about skeletal fluorosis? I think this might be the most common metabolic bone disease, the most common cause of dense bones. And I say this because it's endemic in India, in China, in parts of Africa, in parts of South Africa, where severe bone deformities can occur because the well water, the drinking water, is full of fluoride that comes from volcanic rock, sometimes with vitamin D deficiency. So here's a picture of a village where my reading is that there are tens of millions of people in India that have excessive fluoride in their skeleton, causing skeletal fluorosis. In the United States or Canada, we encountered skeletal fluorosis in a refugee who was coming from here in Kenya, where he came to a refugee camp here, and in his part of it, a borehole had been drilled onto volcanic rock, and these 50,000 people were being exposed to high levels of fluoride. If it's not from well water, we found that maybe not popular in Argentina, but tea is still the world's most popular beverage. And this woman came to me with elevated bone density, Z-scores of +9. She was drinking 2 gallons of instant tea each day, and her skeleton had gone from this to this with an osteomalacia. The tea plant Camellia sinensis accumulates fluoride, and we've seen a number of cases of tea, black tea, associated skeletal fluorosis in the United States, skeletal fluorosis from instant tea or brewed tea. We now see an unfortunate disorder called inhalation abuse, where some people inhale difluoroethane containing computer cleaners, and by some mechanism the fluoride is released, and you get osteitis or periostitis deformans that looks like this clinically And in the hand x-rays, look at the subperiosteal bone. That's a form of skeletal fluorosis. In your clinic, you might use voriconazole. This is a fluoride-containing antifungal that actually, in a normal dose, contains not 4, the upper limit, but 65 milligrams of fluoride. So another source of skeletal fluorosis. Well, what are the good, so-called good forms of dense bone disease? The endosteal hyperostosis, sclerosiosis, Van Buchem, and Wirth type, now called high bone mass. These are disorders of the Wnt beta-catenin signaling pathway. And this simple diagram shows you how Wnt's, when they bind to a frizzled receptor, and then hook up with LRP5 or 6, the beta-catenin signaling is activated, and the osteoblast forms more bone. It's the job of DKK or sclerostin to hook up to the LRP5 or 6, pull it away from this complex, and shut off bone formation. So this requires a dance between sclerostin, LRP5 and 6, and this complex to get bone formation just right. So what is sclerosiosis? It's an autosomal recessive loss of function mutations in SOST encoding sclerostin. So you don't make the inhibitor. The LRP5 or 6 hooks up to frizzled and Wnt, and you get excessive bone formation. The only case I've seen is this boy on the left, his brother's on the right, an engineering student from Saudi Arabia who developed a facial palsy, seen here, cracking headache, had bones that looked like this with sclerosiosis, sometimes syndactylly bony or cutaneous, a skull that looked like this, and interestingly, he complained also of a runny nose, a stuffy nose, and really what was happening to him is he was having CSF rhinorrhea, some of these other complications, so that untreated for what he had was a Chiari malformation. These patients will die at about 30 years of age. He went to successful craniectomy, and his bones looked like this. The osteoblasts were plentiful. He didn't have sclerostin. The osteoblasts were making osteoid, and he had an excessive amount of bone. The sister disease is Van Buchem's, deactivation of a downstream enhancer. If you don't make an enhancer, you won't make sclerostin. So it resembles sclerosiosis carefully, like this. The x-rays look like that. And that is also a result of sclerostin deficiency. So now we move into that complex further. And we see that a mutation in LRP5 can cause, going back to the 1990s, really, a autosomal dominant high bone mass trait. And initially, when this was described out of Omaha, Nebraska, in the United States, it was described as non-syndromic high bone mass. There was nothing else wrong. The patients had very dense, very strong bones. The mutation was identified to be in the first beta propeller of LRP5. That was the mutation. And then a few months later, out of Connecticut in the United States, another family was reported with high bone density, the identical mutation in LRP5, but now there was more to the story. It was syndromic high bone mass, where you might have recalled that as a young girl, this lady's jaw was narrow as a kid, but then became broad. She had a torus palatinus and very dense bones that looked like Omaha. This became a disease when this lady came to me for osteopetrosis, headaches, but I said, you don't have osteopetrosis. She had a facial palsy, trigeminal neuralgia, achy bones everywhere, and a Chiari malformation that would go on to surgery. But instead, exostoses surrounding her posterior teeth, and she had the exact same mutation as the folks in Omaha and in Connecticut. So this became high bone mass, which was a disease. More recently, we found that LRP6 high bone mass is a perfect match, except for one feature, compared to LRP5 high bone mass. LRP5 and 6 are cognate receptors. They do the same thing in that Wnt signaling. And we found in 2 small Missouri families a new explanation, and that is mutation in the first beta propeller of LRP6 causing high bone mass in these 2 families. Look here, this is what the face of a mother and their daughter with LRP5 look like. And here's the mother and her 2 daughters with the same facial appearance. This is LRP6, torus palatinus, but what's missing here, not here, is the maxillary lateral incisor. So that may be a feature, but otherwise their heights, their bone densities, their x-rays are identical. So that was a Missouri experience. And then we had the pleasure of working with Dr. Brance, Dr. Brunn, and colleagues to identify in Argentina LRP6 high bone mass in this college student in your country who was also missing his lateral maxillary incisors, had beautifully dense bones, had never fractured, but was somewhat worrisome, narrowing his optic canal and his auditory canal so that there could be complications later on. So those disorders have taught us a great deal, my last few slides, about good or bad quality dense bone disease. At its worst, you have sclerosiosis, but good quality bone, Van Boeckham's disease. The carriers of sclerosiosis are over here. This is the normal range. The LRP5 and 6 seem to be over here. This is the healthy state. If you go in the opposite direction with these genes, you'll end up with osteoporosis. So wouldn't it be wonderful if somebody was over here with osteoporosis and you could take advantage of these dense bone disorders and their mechanism to increase bone density? So sclerosiosis is a deficiency of sclerostin, and potent inhibitor of bone formation, yes. But if you can match that by using romosozumab, let's say an anti-sclerostin antibody, could you treat osteoporosis? And yes, this led to anabolic therapies. You had the anti-resorptives, you had the bisphosphonates, you took advantage of what you understood to be the rank ligand, rank pathway to make Prolia denosumab. But then anabolics would come along with PTH analogs. In the United States, strontium not approved. But then romosozumab, which is a monoclonal antibody to sclerostin, takes the inhibitor down and switches on the formation of good quality bone. So that's how these disorders lent themselves to improving treatment for low bone density by understanding their mechanism. Just very briefly, we found this disorder, hepatitis C-associated osteosclerosis in St. Louis. In IV drug abusers, we thought maybe something was in the IV drugs, but no, it was hepatitis C that was the true associate. This man crashed his motorcycle many times, but never broke a bone. His bones look like this. And then working with Cheryl Canova and Sundep Khosla, we found that for some reason, the liver of these patients made IGF binding protein 2 in excess and a precursor, IGF-2E. And the combination would penetrate the skeleton. You would get dense bones, but this was never taken advantage by any pharmaceutical company. Caveats, DEXA for high bone mass. Here you're talking about Z-scores, not T-scores. Report these patients for their Z-scores, not their T-scores. Dense bones using DEXA in short people can mislead DEXA. You could have dense bones, but if you're short, you might report out using the aerial bone mineral density of DEXA. a low value or a normal value. And excessively tall people with big bones may cause falsely high BMD values. This is nicely summarized in this paper in Rheumatology 2013 by Gregson and colleagues, friend or foe, high bone mineral density on DEXA. I'll thank you. I hope this has been informative, and I look forward to questions. Maybe I could make a confession. I didn't mean to imply that osteoporosis was a form of dense bone disease. It was more along the lines that, at least in the United States, we would always say osteoporosis is the most common metabolic bone disease. For a while, we would say Paget's was second most common. And we now might say, oh, it's actually renal osteodystrophy that's most common. But the point I was trying to make, coming back to dense bone diseases, was that skeletal fluorosis may actually, if you take a global perspective, be the most common metabolic bone disease. So that's a clarification.
Sí, gracias. Thank you very much, Dr. Whyte. Excellent presentation. Congratulations. Let me translate. Lo que quiso aclarar el Dr. Whyte es que, bueno, él ponía fluorosis como una forma más frecuente de encontrar de huesos densos, pero que en realidad, por supuesto, primero están otras entidades como la osteopetrosis y también habló de otras dos formas de mayor densidad ósea que son más frecuentes que la propia fluorosis. ¿No te parece, Lore?
Sí, totalmente de acuerdo. Thank you, Dr. Whyte, for your conference. It was wonderful. There are some questions. The first is about treatment. You mentioned in osteopetrosis that in which some bone marrow transplantation would be effective, but what about with those where bone marrow transplantation is not indicated? What is the treatment in this case? What do you do with your patients?
Yes, that would be the very rare but very important to recognize rank ligand deficiency. When you have a deficiency of rank, well, that's in the osteoclast. It turns out that over time, I think the clinical severity may actually diminish spontaneously, but there you might not have many osteoclasts because the defect is in rank sitting on the surface of the osteoclast. But if you transplanted and you had hemopoietic precursors, they would then turn into osteoclasts with rank. So that's a osteoclast poor form of osteopetrosis where bone marrow transplantation could at least hypothetically be helpful. But it is the rank ligand deficiency where the osteoblasts and the mesenchymal cells aren't making rank ligand that won't be fixed by bone marrow transplantation. You're not fixing the osteoblast or the mesenchymal cell to make more rank ligand. So marrow transplantation, conventional bone marrow transplantation doesn't work. And there, unfortunately, there is no, to my knowledge, established medical therapy. It would be wonderful if you could administer rank ligand, but I don't think that's been made available from any pharmaceutical company to be given to these very rare pediatric patients.
Thank you so much. Sí, aquí me parece, Lorena, que lo interesante es que el trasplante de médula no serviría en los casos de osteopetrosis donde hay deficiencia del rank ligando, dice el doctor, donde habría que reconocer si la deficiencia es entonces del rank ligando, donde severamente disminuyen los osteoclastos, y generando el trasplante, no podríamos hacer funcionar a las células mesenquimatosas para producir el ligando. No estaría indicado en este tipo de osteopetrosis y todavía la industria farmacéutica no ha generado esta molécula de RANG ligando como para dar al paciente y mejorarle la posibilidad de activación del osteoclasto.
Yes, so in the United States, you could think of doing, let's say, a conventional bone marrow biopsy to see if there were osteoclasts as a way of distinguishing. But now available to us in a number of commercial laboratories are so-called Osteopetrosis DNA panels. And they would give you, with probably 95% likelihood, finding the underlying mutation. So you'll be able to use DNA to look for rank ligand deficiency without doing a biopsy.
Thank you so much. Let me translate, please. Lo que el doctor dice es que en realidad, además, en vez de hacerse una biopsia en Estados Unidos, la biopsia de médula ósea para ver los osteoclastos y evaluar de esa manera la deficiencia, en realidad también hay la posibilidad de generar, de hacer un test con el panel de DNA, de ADN, lo que se llama el panel de osteopetrosis de ADN, donde da un 95% de probabilidad para encontrar la mutación.
Exactamente, hacer el estudio genético y en lo anterior evaluar la severidad y lo que mencionaba la presencia, actividad o no de osteoclastos. The second question is about vitamin D as part of the treatment of osteopetrosis. What do you think about it?
Many years ago, I think Francis Gloria in Montreal, Canada. No, that was giving PTH. He gave PTH, probably bovine PTH, to a patient with osteopetrosis and thought that there was some improvement. The question about vitamin D then is probably going back to the work of the late Dr. Lyndon Key. Not vitamin D, but calcitriol. He reported in the New England Journal of Medicine how an infant with malignant osteopetrosis seemed to respond to very high doses of calcitriol. Somehow you would think activating the osteoclast to chew away the skeleton, but if you went in that direction, you'd have to have the patient on very low dietary calcium intake. Otherwise, the very high calcitriol would absorb dietary calcium and you'd end up with hypercalcemia, hypercalciuria, and renal damage. And lacking bone marrow transplantation, lacking what we needed 30 years ago, there were a number of clinicians who tried giving high calcitriol, low calcium diets to these patients, but it was very difficult, as you can imagine, to manage. And I don't think there was any subsequent substantiation that it worked. So certainly, I would say maybe 10 years ago, maybe 15 years ago, the idea of using calcitriol vitamin D has fallen by the wayside. It's not done anymore. What Lyndon Key did subsequently find is thinking that superoxide that could be generated by interferon. He gave interferon gamma 1B to maybe 10 infants with malignant osteopetrosis. And I actually wrote the editorial for the New England Journal of Medicine after looking at the paper and showed that I think hematocrits improved, less infection, and that then became a potential treatment for malignant osteopetrosis, fell by the wayside until maybe 5-6 years ago when Actimmune was sort of regenerated in the United States, not reinvented, but sort of rediscovered, and then became approved for malignant osteopetrosis as maybe a means of treating the patients, hoping that they can then go on to bone marrow transplantation. So this is the work of Lyndon Key, a wonderful clinician who got involved with malignant osteopetrosis, so challenging, and then made those observations.
Thank you so much. Please, I will translate. Lo que el doctor Whyte explica es que el doctor Glorieux hace unos años se preguntó él mismo si la paratormona podía ser un tratamiento con mejoría en la osteopetrosis, pero en realidad lo que se vio era que el calcitriol, era que la paratormona al estimular la producción de calcitriol tenía una respuesta positiva en estas osteopetrosis malignas. Todos estos trabajos son muy importantes por parte del clínico Lyndon Key, en osteopetrosis maligna. Pero lo que me pareció muy interesante es que el calcitriol activaría al osteoclasto para aumentar el metabolismo óseo y comerse, de chew, ¿no? Morder el hueso, poder resorber hueso, que es lo que él quiere. De todas maneras, estos trabajos, esto ya no se usa más desde hace unos 10 años o más, pero hace 30 años se intentaba dar con muy baja dieta cálcica el calcitriol, bajo calcio para no absorber tanto calcio, por supuesto, para no tener hipercalcemia, hipercalciuria y daño renal, porque bueno, en ese momento no estaba el trasplante de médula como una opción. Entonces se trataba de hacer un manejo que él piensa que no era del todo sustancial, no es tan importante. Y desde hace 10 años eso ya no se usa, y lo que sí habló del interferón gamma B, que por una acción, si entendí bien, de la superóxido dismutasa, daría también un beneficio a los chicos, vos Lorena corregime, con menores infecciones, con una corrección de la osteopetrosis en ellos.
Comprendí lo mismo que vos. And what about in cases of high bone mass disease? What do you think about treatment in these kinds of patients?
In the high bone mass disorders, LRP5 and LRP6 high bone mass, the bone quality is superb. These patients don't fracture, but the disease part of it is the accumulation of high quality but too much bone in the skull. And that leads then to the cranial nerve problems. And you can imagine maybe there's excessive bone formation at the inner table of the skull, leading to maybe raised intracranial pressure or Chiari malformation. And this requires surgery. That engineering student that I showed you with a very good quality skull bone, lots of trabecular bone with lots of osteoblasts, you have to warn the surgeons, the neurosurgeons, about the high quality bone. 6 drill bits were burnt out going into that young student's skull to relieve the Chiari malformation. So I see it as currently a disorder that especially the neurosurgeons become involved with. But in other instances, these patients can appear to be non-syndromic, really quite healthy as first thought, but then syndromic because they have the torus palatinus and the teeth that are encased with dental problems. Maybe not much more than that, but then, like I showed you, the woman who was thought to have osteopetrosis but had much more. So it varies from affected individual from one to another. And I know of one LRP5 case where craniectomy was necessary, I think in a Black woman living in the south of the United States who had an LRP5 mutation, but big sort of skull difficulties during childhood. So there's going to be variability from one patient to another.
Thank you so much. Lo que me encantó la pregunta de la doctora Lorena Brance con respecto a los desórdenes de alta masa ósea, pero que no dan deterioro de la calidad, o no estaría en especial deteriorado en la calidad, la estructura ósea, y que entonces no se fracturan. Pero lo que ocurre sí pueden ser sindrómicos, los defectos del receptor LPR5 o 6, que hablaba de alta masa ósea, pero sin fracturas. De todas maneras puede traer aumento en la calota, aumento en la base del cráneo, y esto generar entonces compresión medular, presión medular. Hay que avisarle a los neurocirujanos porque rompen entre 5 a 6 en cada acción quirúrgica de estos pacientes, rompen 5 a 6 de los drills, de los perforadores. Están muy involucrados los neurocirujanos en esto. Sin embargo, puede traer diferentes manifestaciones como torus, lo que veíamos que el sobrehueso en el paladar, los problemas dentales. Es muy individual, y vio una craneotomía necesaria en una señora, en una mujer negra, en un caso en Estados Unidos. Así que la verdad que tampoco parece el mejor de los mundos.
Well, because of the time, I think we must to finish this meeting. Thank you very much, Dr. Michael Whyte, for your presence, for your conference, for all of the questions. And thank you very much for Dr. Paula Ray. It was a pleasure to share this meeting with you.
Yes, thank you for the wonderful questions. It was a great pleasure giving the talk and having it so well translated.
Thank you for your answers, and thank you, Dr. Lorena.
Yes,